Welcome everyone to one of our BEI programs here. It's great to have our scholar in residence, Martin Pusic. My name's Eric Alexander. I'm Executive Director of the BEI, and we love continuing to have new faces and old faces join us whenever your schedule allows, and also bring new ideas and new speakers to us. It really is a fun forum. And today's session is the part 2 of another great new series here we've been able to put on of this great talk here. And we had a really fun time at the last one. Martin, I welcome you back. Thank you for everything. I'll turn it over to you, actually, Martin.
Great. Thanks, Eric, and thank you for all of you who've come to the session. And just to situate it, the last time we talked about the way we learn to perceive the world, and we did some pediatrics. I'm a pediatric emergency doctor, and so the way children develop their sense of kind of how sensory input comes in and how to make sense out of the world, and then talked about neuroplasticity and the ways in which we would teach to the plastic potential of our brain. And the argument there was that as adults, we still have plastic brains, and that we can learn, sort of deep into old age, and our brain rewires itself and comes across. And so in this second one, we're going to cone this down and make it more medical, and we're gonna focus on visual diagnosis, and visual diagnosis being an umbrella term for what are classically we think of as radiologists doing. Kind of they look at images and make determinations, but probably you can make an argument for visual diagnosis in every specialty, and so that whether you're a cardiologist reading electrocardiograms, a dermatologist looking at skin, and so on. There's a certain part of us looking at visual findings and then making a determination, normal, abnormal, or what the diagnosis is. And so we're going to be on that general level. This isn't a radiology talk; it's a medical education talk. But to bring in some cognitive neuroscience, and hence the hint at the way people have played with how pigeons and gorillas and kind of all of them make diagnoses as well. I'm hailing to you live and direct from Calgary, Alberta, where there's a fantastic group that looks at neuroplasticity and visual diagnosis and that kind of stuff. And we're setting up collaborations. And so I think Kent Hecker's on the line, and kind of it's a privilege, in an academic career to be able to go and share ideas. And so this will be part and parcel of it. And the cartoon alludes to the fact that I'm Canadian, and I keep trying to fit into Boston culture, and the Red Sox are so important, and so that but I absolutely loved it when I saw this particular slide where the guy's holding a curling rock and going to bring it across, and so that the misconceptions are, I think, useful in terms of us thinking about the way we approach things on either side of the border. So away we go. And so so what I'd like to do is look more closely at the cognitive underpinnings of visual diagnosis in general, and all the way through, and especially at the end, weave in what the educational implications are. And so this is a different way of looking at visual diagnosis, and the implications are considerable in changing the way that we teach from business as usual. So that's the claim. You'll tell me whether I've succeeded, but similarly chime in. There aren't going to be any breakout sessions. There aren't going to be any kind of fancy group work and the whole bit. Instead, I'm going to lay out ideas, and what would be great for me is I'll try and keep the chat box up as we go along, and but feel free to unmute, and we can go from there. So in that spirit, Michan, yes, diagnosis is a big word. We'll get into that, and so that let's move it along. So how do I get this? Sorry, the resolution on this. So I'm going to start with the case. And so it's Friday night. It's Bellevue's emergency department. That's where I worked at before I came here. And it's 5 o'clock, and we're doing sign over. And my colleague Mike Tunick had done the day shift, and I'm coming on for the evening shift. we're sitting there at the sign over. We talked about the patients. I've gotten up to date, and he's hanging around and kind of not racing off. And so we're chatting about kind of baseball or something. And a resident puts a case up on the viewing box, and the viewing box is about 20 feet from where we are, but we can see it on fast. And Mike looks at the viewing box and he goes, do you see what they're looking at? And I look over and go, yeah. And what they were looking at, was this X-ray. And from 20 feet away, Mike and I could tell what was wrong with this X-ray. And it turns out that this X-ray is a huge deal for emerge docs, because this is a difficult diagnosis to make visually. But if you miss the diagnosis, the person's wrist, this is the lateral view of a person's wrist. And so up here at the top is the first finger, I think, and here's the thumb and the like. And so that you're, and then the forearm down here. And so that if you miss this X-ray, you doom the person, because it requires an operation to fix it. If you don't do the operation in a timely fashion, the person has arthritis in their wrist forever. And so, kind of huge medical legal implications and the like. And so it's really cuts to the essence of what we do, in the sense of difficult diagnoses that you have to be on the lookout for, but it's rare. We don't see it very often, and bring it across. And so Mike and I look, and from 20 feet away, we can tell this is what the diagnosis is, even though each of us rarely ever sees this particular diagnosis. But we've been so tuned, so worried, so scared of missing this diagnosis that we can do it. We can do it, and we're trained. And meanwhile, the residents, this is Bellevue, and there's like 12 residents on that Friday evening, and they're gathered around the thing, and they don't see it, and so that they're talking about it, and so Mike and I lob from 20 feet away is that X-ray is abnormal. Can you tell us how? And so even with the clue that the X-ray is abnormal, they look through and they can't figure it out. And this is a series of residents from R1s to R3s, different things and the like. And so we let them swim in that, because we're evil old educators who are perfectly comfortable with with inflicting uncertainty on our poor learners. And so there are value judgments there, I know. And so, but bear with me. And then I pull up, I go onto Google Images and I pull up a normal wrist. And so that I flash up a normal wrist. And when I flash up a normal wrist, and it shows up on the monitor right beside the abnormal one, suddenly they all get it. And suddenly they can make the diagnosis. And can you see it now? Does anybody want to chime in? Are there any emerge docs in the audience, or kind of people who know what the diagnosis is here? Some sort of commentary on the support of my research by emergency doctors. So this is a lunate dislocation. And so on the normal on the left here, you can see that your lunate supports whatever bone it is above it, and they all line up beautifully. Right. And so, but what has happened in this 20-year-old's fall is that their lunate, which used to be, kind of cup underneath here and sit and be the transmitter of forces between the distal radius and the carpal bone above it, has dislocated and is now facing in completely the wrong place, and its articular surface is nowhere near the carpal bone that it's supposed to intersect with. And so that what the surgery is to put this thing back and, kind of get it to go back here so that it's in the spot where it's at. And so you can see that missing this, kind of completely balls up your wrist and brings it across. And so that, so that very, very important to diagnose this. And Mike and I make the point with the residents. We make it a teaching point. There's, 15 people gathered around the viewing box, and it's really, really great. And so then, and this is not a word of a lie, a radiologist walks into the emergency department, and he's there for some completely unrelated reason. And he looks from 20 feet away and says, good lunate dislocation. And Mike and I look at each other and say, we're pretty smug about the fact that we saw it too, and kind of feeling pretty good about that and the whole bit. And then he tosses off, this is still from 20 feet away, goes, did you see the fracture of the radius as well? And Mike and I go, what? And so if you look at the AP view of the thing, so that there's a small tiny fracture off the distal end of the radius on the medial side, and so that he's got a fracture there as well. And so there's a truism in radiology about what's the most commonly missed fracture, and the answer is the second one. And so that there's a human tendency to go, kind of see the spectacular thing, to focus on that, and to call off the search after that. And radiologists are trained not to do that, and so that they sort of meticulously go through and look all the way across, and then can pick up things in a more comprehensive fashion. And so I tell this case because it's a great example of how, with training, we develop an information extractor mechanism that can look at a noisy environment like a wrist X-ray and see the patterns that are there, and see the patterns in an adaptive sense that allows us to pick out exactly the features that allow us to accomplish the goal, in this case, diagnosing fractures. But it might be, kind of the same as in the way a baseball batter can pick up the seams on the ball at the release point of the pitcher's motion, and has been trained to develop a mental model of what a curveball looks like compared to what a fastball looks like, based on that few milliseconds at the release point of the pitch. And so in this talk, we're going to talk about, kind of how people developed that incredible ability to pull, that a radiologist can wander through and from 20 feet away identify this subtle fracture. I still have my suspicions that he'd seen it back in his dark room and had wandered through in order to only show off, but I can't prove that. And but here it makes the point of my talk, and so that we'll stick with it. Okay, so with that case setting us up, I want to present a study that we did, and the study is a voice aloud study, and I'm going to show it in two parts. And what we did with the voice aloud study, we've done a number of studies where we show people X-rays and then say, kind of what's the diagnosis, and then they either get it right or get it wrong. We give them feedback, and then we give them another case, and then they do the same thing, and another case, and we plot out learning curves, and we kind of get a sense of kind of how often they're right and how they learn with feedback. And so that's all well and good and gives us insight in terms of the way people learn. But we wanted to dig deeper to figure out what exactly is happening as the person diagnoses the X-ray. And so in this study, what we did was we took some pediatric radiologists and some medical students on their radiology rotation. And we had them each read pediatric elbow X-rays over a 1 hour period, as many as they could read in an hour. But while they were reading them, we had them voice aloud. We had them think aloud. This is a research technique that I'll situate in a second. But the gist of the idea is to not collect their theories and ideas around it, but instead collect a kind of stream of consciousness of what they're paying attention to. And in collecting that stream of consciousness, we would get insights as to what features in this noisy domain that they were in fact paying attention to, and allow us to, kind of figure out how they were learning as they went along. And so that the study involves sort of was quite a collaborative thing, but but Anders Ericsson, the guru who's responsible for the 10,000 hours rule, who sadly died a couple of years ago, but very incredibly accomplished cognitive psychology researcher, and then his grad student Jong Sung Yoon came up to New York again in one of these fantastic academic collaborations and taught us how to do this think aloud protocol. And then Nancy Pfefferman is a pediatric radiologist, and Kathy Budis and Marty Picharko, my collaborators up in Toronto. And so kind of what we did was we did this expert novice comparison. So you can't get more bold than in terms of an expert novice comparison than comparing pediatric radiologists. So not only are they radiologists, they've done a subspecialty in pediatrics, looking at a pediatric topic, elbow x-rays, and then third-year medical students who wandered through on their radiology rotation, who are trying to learn all of radiology in a month, and of which pediatric elbows would be just the narrowest part. But we wanted to use this absolute bold dichotomy to understand, kind of what happens when you're learning and what happens when you're fully baked in terms of being a radiologist. And so so 7 medical students, 4 pediatric radiologists. The intervention sort of in the PICO thing is that you're a novice and the comparison is an expert. And the outcome are these verbal protocols, kind of this think aloud stream of consciousness type of thing. And what we did of these people is a 60-minute session in which they had to diagnose the radiograph, and I'll show you in a second, and then we gave them feedback. And so that with each case, presumably the pediatric radiologists are learning nothing, they're just doing their work. Whereas with each case, these medical students would be learning a great deal, and they're a kind of a tabula rasa. And then with each case, they would be learning tremendous amounts in terms of their worldview of pediatric elbow x-rays. We recorded every utterance, we transcribed it, and then we coded that, and then obviously reported the accuracy and the time per case. And so this is what the pediatric elbow x-ray thing showed, is that the person would see an elbow x-ray, they would place a red dot on the thing that they thought was a fracture, and then they would click submit. And after they click submit, up comes this feedback screen that shows them a yellow box of, kind of what would have been the right answer. So in this case, the person got the answer right. It would give them a glorious green check when they got it right, and a big red X that when they got it wrong. Old school education still. And then but this is in the comfort of kind of a research study. And then it would give them text from the radiologist's report to give them a sense of kind of what they're seeing, and so that the text would say something like, this is a fracture of the coracoid process of the ulna, and so on, and give you that as the feedback. And so so again, to situate this research method as an elicitation technique, kind of typically we teach with rationalizations, kind of if the medical student were learning from a pediatric radiologist, the pediatric radiologist would be explaining, I think of it this way, that way, and when you see this, you should think of that, and that kind of stuff. We didn't want that. Okay, so what we wanted was data on what was happening with their psychological processes, and that's where the voice aloud comes in that they were explicitly instructed, and I'll show you, to not do that, but rather to stream of consciousness report their information. You can do more sophisticated things like they do here in Calgary in terms of track people's eyes to get a sense of what's happening from a psychological standpoint, or you can strap on EEGs or insert them into an fMRI and again, sort of get a deeper sense of the cognitive processes involved in visual diagnosis. We didn't do that, but I just want to show you the spectrum and where we were in terms of these particular elicitation techniques and how close you get to what's actually happening in the brain. And so there was a 10-minute instruction phase in terms of teaching the person how to do voice aloud. And I'm not going to go through that in detail, but again, to reinforce that this is different from what we do when we teach in radiology, is that we told them, don't try to plan or explain what you say, just talk. And so that as if you're alone and speaking to yourself, and then keep talking while you're coming up with the answer to each and every question. And so that if there were pauses, if they didn't talk, if whatever, we would be saying, can you verbalize catalytic responses? And really what an ideal case was them considering the case. I'm now looking at the electronon. Now I'm looking at the proximal radius and so on, with all of their words as to what they were paying attention to and bringing it across. And so that we recorded that and coded it all. And what that looked like was, kind of up at the top here, we had these the data was 191 verbal protocols, 191 x-rays cases read, with the novices accomplishing 102 of them. They're obviously slower and don't do as many cases as the experts. And so that the 4 experts did many more cases over the course of an hour. We masked all of these transcripts as to whether they were from a radiologist or from a student, and then coded them line by line in this qualitative software. And we tagged them for the presence or absence of a code, and then dumped that into Excel, and then started to make comparisons between the experts and novices. And so this was a love child of a qualitative, quantitative, mixed methods, think aloud type of thing, in the sense of that the methods were, kind of borrowed from each of these transitions, but again, for us to understand what's happening on a cognitive basis with these particular learners. And so that so we were sensitized by, there's a lot known about how you should read pediatric elbow x-rays. And so this is a state-of-the-art review on, kind of what you should look for in terms of pediatric elbow x-rays. And so you can see there's a lot there in terms of all of that. And so we came to it looking for descriptions of these particular things. But in addition, we let codes emerge, we constructed codes to, if we saw something different from what was being identified here. And so I'm going to give you those themes in a second. And so there were some process checks. Obviously, if we found that the radiologists were only as good as the medical students, then we don't have a very good study. And so that so thankfully the radiologists were way better than the medical students, and so that M equals the mean accuracy, and so that so the 72% correct for the radiologists and 37% correct with the medical students, and we can get into the details of that as to why the pediatric radiologists weren't 100%, and but the gist of it being that we chose very difficult pediatric elbow x-rays in order to be sure that we're seeing the full flower of the phenomenon. And then the other thing is that the radiologists were faster than the medical students, but we've seen this in other research, is that the radiologists are also more conscientious than the medical students. And so when a radiologist spends 100 seconds, they're accomplishing a lot in that 100 seconds compared to the medical students. And so that, but again, you would expect the radiologists to be faster, and indeed they were. Yes, Dr. Katz, 72% correct. And again, kind of part of it being that we were strapping them into a low resolution PC laptop that did all this recording and the like, and they wanted their souped up 47-inch screens where they can zoom and pan and all of that kind of stuff. So we're definitely taking them out of their comfort zone in terms of, kind of where they were at with the cases. So that there are a number of things there, but the important for this study was that they were better than the medical students, and they were able to show their expertise in the recordings and transcriptions. Where am I there? Yeah, good. And so the key results were that there were 4 main themes, and we're going to spend some time on each of these, and we're going to connect these to the literature. And so that the 4 main processes that we saw were, first off, something that we called Gestalt. And that's kind of a flash thing in which they would look at the thing, and they would immediately say that, like, the first words out of their mouths were, there's a fracture of the proximal olecranon. And so there wasn't words saying, you know, I'm looking at this, I'm looking at that, I'm sort of gradually, and then eventually, voila, I found Waldo, you know, so using my thing. Yes, Kent, non-analytic would be the, you know, sort of the thing, the proper research term, if you will. But a gestalt we use the word in the sense of, you know, kind of not thinking about it, but rather reacting, and without any process, arriving at the answer, arriving at the feature. What we also saw evidence of, and I'll get into each of these in more detail, so I'm just giving you the overview right now, is if they didn't gestalt the thing, then they did a careful search, and the experts were different in their careful search compared to the novices. And then the third thing was rule application. There are rules to this that can help you do this better, and the rules represent wisdom handed down from one generation to the other. And so that the rules, you would imagine in the expert novice thing, the experts know the rules, or those novices don't, and we'll discuss the implications of that. And so you can see that careful search and rule application lend themselves to regular education. How do you educate for Gestalt is the interesting question that we're going to explore. The other thing that was interesting for us that we'd seen that was the novel thing within this is that we could see within the transcripts the medical students learning. And what that looked like was, you know, on the last case, I clicked here and I got it wrong. So on this case, it must be that the anterior fat pad is not emblematic of fractures, and therefore I will not click on the anterior fat pad, and I'm going to accept that as normal, and I'm going to move on to the other features. And so that we could see the medical students hearkening back to previous cases and using what they had learned on the previous cases to apply to this particular case. Of course, the pediatric radiologists did no such thing, and we never heard them referring to prior cases. And from the literature, we know that a good radiologist has, you know, kind of basically a Vulcan mind wipe between their cases and are not influenced by prior cases as they go along. Okay, so excellent. So let's go deeper into some of this. And so I'm not going to go through this slide in any detail, but the gist of it being that when you measure and count these things and compare them with the expert against the student, they're all statistically significant differences, and, you know, of magnitude, and you can argue about that. This was not our focus. We just wanted there to be differences, and there are indeed. But what we've surfaced is, in essence, the qualitative analysis of each of these things. And so the Gestalt, this is what this looked like. And so that so here's the example of an elbow X-ray that has a fracture along here at the proximal ulna, and the person put their red X, you know, in the right place. Whoops, I drew the fracture in the wrong place. Embarrassing at your own talk. And so here it is here inside the yellow box. And so that the person got this right. And then here's their utterance. This is an AP view radiograph of the right elbow. It's a 5-year-old female with the right elbow injury, marked swelling, pain. We gave them some history as we went along. So when they read the history out, that's in our transcript. And then immediately after reading out the history, they look at the film, and it says the proximal ulna looks a bit abnormal. I'm seeing streaky lucencies through it, and then places the X on it. And so that's what that looked like. And so we just go. And then here's another person looking at the same case, and so that again they read the history up here, and so I'm looking at the AP view, and so I'm showing you the lateral. But what I'm seeing is some linear lucencies through the proximal ulna. Again, their first real utterance is to show the particular thing. And then, you know, kind of here's one that was an accident. And so we put in this pediatric elbow X-ray, and this elbow X-ray was taken with the person having their, you know, kind of sling on, and the sling being tied to them with a safety pin. And so, of course, kind of the first thing the person says is there's a safety pin on the thing. And so it's an example of real human gestalt. And so that they're not, it's from their everyday experience, they've got a sense of, kind of what happens there. And indeed, it's a kind of process check on our thing, and that the medical students would gestalt this, whereas the radiologists would gestalt those thin streaky lucencies and bring it across. And so it's a testament to our training that we can recognize fractures on x-rays the way an ordinary human can recognize a safety pin within, kind of the environment as you go along. And so that brings us to, kind of this gestalt, this automatic thing, this I recognize a safety pin, kind of how does that work? What part of the brain is involved in that, and how do I teach that? And so, so I want to show you this study, partly because it makes my point, but partly because it's so fun. And so that so this is a group that are of well-known visual diagnosis experts. And so these are people who are agnostic to whether it's radiology, pathology, dermatology, whatever. They just care about the process of visual diagnosis. And so that they basically strapped a pigeon into a box, and then showed the pigeon images, and they showed the images of was it in terms of kind of where they had to find particular findings. I'm blanking now on whether they were looking for nodules in mammograms or the thing. I can't remember what the gist of it was. Normal images and abnormal.
Right to me, Mark.
Say it again.
Looks like the thyroid to me.
Okay, good. So the and it kind of makes my point in a way that is again embarrassing. That what the stimulus is generic to normal, abnormal, finding a needle in the haystack. But the setup was that the pigeon had to peck at a certain lever, and if the lever was on the right, that meant there's a nodule there. If it was on the left, that meant there wasn't a finding there. And if they got it correct, kind of again in a 2x2 true positive, true negative type of fashion, they got rewarded with a pellet. And so that and they would flash cases in front of them in a way not that dissimilar to what we did with the medical students and the pediatric radiologists. And so that there we go. So that mammography images and breast histopathology. It was the histopathology that I'd forgotten. So that I'm still looking at what Eric claims is thyroid. But they went through and did this, and then looked at the learning curves of these pigeons and looked at whether or not they were above chance in terms of making this medical diagnosis. And so that how did they do? So here's what a benign sample is. Here's what a malignant sample looks like. Sorry, I can't tell, but the pigeons sure can. And so that so here's the mammography task, and so the benign masses versus malignant masses. And so these weren't toy problems in terms of kind of that that this has nothing in it and this has huge ginormous tumor to it. You could make an argument for the confusability of these particular images, and they're an image set that allows you to determine, when to some extent, an area under the ROC curve of how good a radiologist the pigeon is. And so they generated, they showed these images, they gave the reinforcement feedback, and then generated learning curves and ROC curves that you would be proud of as a visual diagnosis researcher. And so here's what it looks like, and so what you see is they've measured on the x-axis the number of days they've been working away at this particular task, and then we'll pay attention. The different magnifications, 4 times, 10 times, 20 times. It's an easier task if you have it magnified. But they start off at chance at 50%, and they show a beautiful power law learning curve that goes up and then it kind of eventually levels out at 90% or so, the level of accuracy within, in terms of their terminal ability as they got trained, and they had a post-test as well with no feedback that they're able to read these things, and you can make an argument for it. And then this is my favorite slide in here, so that so these are numbers for each. These are unromantic numbers for the name of the pigeon. So this is 45W, 71R, 28Y, and the whole bit. But then they have an ROC curve that they refer to as the flock ROC curve. And so if you created a rule amongst the 4 pigeons, you could do even better than any individual pigeon, and you would have an area under the ROC curve that was with your flock O pigeons that would be, kind of credible in terms of, we'll argue whether it's credible or not, but the point is that this is way above chance. Clearly the pigeons are learning, and clearly the pigeons, to whatever greater or lesser extent, can discern on a medical thing. Thank you, Susan. An ROC curve is a receiver operator characteristic curve, and what would be a bad ROC curve is a curve that just thinly above this flat line, because that means the flat line is chance, and so you're only as good as chance, and so that goes across there. Whereas a perfect ROC curve would look like this, would be a complete square, and you would be kind of perfectly sensitive and specific as you go along. And so it's a measure of goodness that we apply to radiologists and to diagnostic tests and the like. And so that this ROC curve is not as good as the flock ROC curve you can see up here on the top left, which is highlighted in bold there. So again, that was for the histology. For the mammograms, again, a learning curve that, kind of fast initial learning that plateaus off. And again, they're not as good at this particular task. It's a noisier task, but they get to a level of goodness that is certainly different than, kind of 50% chance in here. So that, so the point being that here's the words from their paper, which I think are fascinating. The specific underlying mechanisms of visual learning appear to be similar between avians and primates, despite some, and I love the exuberance of this, despite some 300 million years of evolutionary divergence and structural neuroanatomical disparities. Structural neuroanatomical disparity means that a pigeon's brain is this big and our brains are this big, and that you can't get more structurally disparate in terms of that. And yet pigeons have a tremendous need to be able to discriminate their environment and food, not food type of thing. And so that you can imagine that that comes across. And so here's evidence along those lines. And so that so this is a CT scan, and in the CT scan, the radiologist's job is to detect tumors. And so can any of you, using the annotate function in Zoom, highlight the tumor seen on this lung CT?
I don't know how to use that function.
That's my stealth agenda in terms of teaching. And so take your mouse to the top of your screen, and the Zoom toolbar will come down, and about 3 or 4 from the right is a pen-like icon that says annotate. Click on that, and then when you click on that, up comes a confusing additional toolbar, but about 4th from the left is the word draw with a wavy line. Click on that, and then it allows you to do the thing. So that fantastic. We couldn't fool you all. Whoops, I cleared them all. I didn't mean to do that. But this here is a gorilla. And so that they showed expert radiologists who do this for a living, whose job is to scan CT scans for pulmonary nodules. And they showed them this and said, can you read this in your usual manner? These radiologists, these fully trained, board certified radiologists went through and did this and did not see the gorilla. So think about the implications of that. And so that is that they have such a finely tuned information extractor that looks at this noisy environment, and they strap them into an eye tracking thing, so that they eye tracked them and looked at where their eyes looked, and they proved that their eyes in fact looked at the gorilla, and then went onwards without recognizing it as a gorilla, and looked at the other parts of the thing. And so despite looking directly at the gorilla, they didn't pull it back. And the gist of it is that, remember, this is no reflection whatsoever, and in fact could be kind of a left field indicator of competence, in the sense that you have such a well-developed information extractor for the features in your chosen environment that you don't get distracted by things that are completely extraneous to the things that you're looking for. The kind of focus that has been trained into you, that works against you from an everyday thing. And so that if you showed this to me and you, non-experts on CT scans for pulmonary nodules, it's the gorilla that interests us, and that we can see, and that we would be open to seeing, because it's all new. So you might as well sort of have the gorilla in there. And so that we're not target focused, we don't have the information extractor built into us, and so that we don't think of it as a distraction from what we're doing. In fact, it looks like a feature as you go across. So this Gestalt phenomenon is, and this is my teaching point within this, is the idea that, I'm going to skip that case for us, the idea that we can teach for Gestalt, but we have to teach in a pigeon-like manner. And what I mean by that is that we have to show you example, non-example, feedback, over and over and over again, in a way that is almost military. You can assemble a gun in the night, in a muddy trench, and the whole bit, so that we've trained your brainstem, your occiput, wherever this lives, in a way that is independent of our words as they come across. And so that there's a separate learning curve along those lines, but that we can also marvel at how great that is in terms of coming across, and it can be such a powerful thing that we built that we miss gorillas as we come across. Great. Okay, super. So the yes, search satisfaction, but in a way, missing the gorilla is, kind of, these are radiologists whose search patterns would have been developed in them to be not missing things. Per my example before of the second fracture that I missed, but the radiologist didn't, and so that but search satisfaction is certainly a theme. So let's go through some more of these themes, and so that so careful search, and I'm just going to blow through these a little bit, but what we saw in the experts that was different from the novices is that they use better language. So as they went down through their search, they had an anatomical term for proximal electronon, head of the radius, trochlea, capitellum, growth plate, internal epicondyle, so on. And so that so all of that whereas the medical students used vague terms that were left over from their anatomy learning. And so that part of learning within this domain is learning the richness of the vocabulary and arborizing your mental model on how to speak about it, because in speaking about it and having a language for it, you can then learn well. If you remember, part of the feedback here was language. And so that the language would have used these particular jargony terms. And so your ability to extract good feedback from the language depended on you knowing the words. And so that the expert novice, this is not a surprising thing, but from an education standpoint, the idea of a semantic qualifier, this is a small posterior fat pad, this is a medium posterior fat pad, this is a humongous posterior fat pad. Learning that language and calibrating and bringing it across is clearly part of the educational process and was important for reading these particular things. That one, not so surprising. Rule application is interesting because this hasn't really been brought across a lot. What do you guys think of this? So I'm on in the emergency department. We're about to do a lumbar puncture on a 3-week-old, and I'm going to help this senior resident figure out how to do that. And so I Google lumbar puncture anatomy so that I can show the senior resident the lumbar puncture anatomy. And on the Google images hit list, this is about number 17. What do you think of it? Put it in the chat. Yeah, there's that. Don't use that kind of needle. Okay,
going the wrong direction.
Like completely the wrong direction. To do this, what you see here, you would have to go through the belly button, through the intestines, and then through the fascia, and then put it in, because this is the, if I can draw it here, where's my thing? This is the front of the patient. This is the belly button somewhere in here. And you would be sort of going through all the guts in order to get to the spine, the thing. So the way a lumbar puncture is done is from over here and goes through, and then you get to the spinal canal there. So this is completely, entirely anatomically wrong. And yet you have to have a sense of anterior and posterior. And I think it's a super useful guide, because a first-time medical student thinking about a lumbar puncture, when you talk about interspaces and you go through the L4-5 interspace, I guarantee you that what they're thinking of as interspace is in fact the intervertebral disc. And that would be a normal confusion that a completely novice person would have, and that you're going to put the needle through that. And so here's a canonization of that faulty mental model, and bring it across. And so the reason I interject that here in this talk is that there are rules that we use to make sense of the world. And you could have my medical students in this study do x-rays till the cows come home. They won't derive these rules except, kind of by chance a long time later, because these rules were discovered by some radiologists. They were published in the peer review literature, and then finally brought forth, kind of as a definitive thing that radiologists could use. And so this is what real teaching looks like, is accumulated wisdom and then passing that on to the next generation with a thing across those. And so in our voice allows, the medical students never use the rules because they don't know them. The pediatric radiologists use the rules, but they use the rules not in every case. So they didn't draw these particular lines that you're supposed to draw when you're worried about a radial head dislocation, but they only invoked them in those cases where they were relevant, so that they had a mental model of when the rule might be useful, and didn't clutter up their process by invoking the rules slavishly on every single case. But instead, we could see them thinking, okay, this is a borderline case, I better draw my lines. And then they would draw their lines in the cases where they needed to. So that was fascinating to us. And so that there's wording along those lines as well. And then this reasoning with the prior case I hinted at earlier in terms of the kind of medical students kind of using case 2 to logic about case 6 and bring it across. And so it was really quite exciting to be able to watch learning happening within the transcripts and see the people sorting out their world as they came across. And so and we could see sequence effects. And again, if you create a flippy sequence, normal, abnormal, normal, abnormal, normal, abnormal, then the person answering the questions flips into that sequence and is more likely to flip their answer. Whereas you do things in streaks, they become streaky. And again, that has pedagogic value in that you're not supposed to do that. And in fact, we can show in other studies that learners are prone to this and fully baked radiologists are not. And then I'm going to finish on this. Again, talking about the educational implications is the youth orchestra example. And so that I don't know how many of you were in youth orchestras, but I was, and played the viola badly in the section. And we would rehearse all year in order to be able to present to our parents and other people who had to be there, Carmen. And so you know, in my defense, I think we did a good job. And what we did, which is different from a professional orchestra, is that we spent a year of Saturday mornings doing this until we could do the thing to a serviceable rendition. Whereas a professional orchestra would rehearse it for half an hour and then they would fire. And so the true expertise. But the point I make is that this created a mental model in us as 13-year-olds of what it is to be a professional musician, and the eventual ones of us who become professional musicians have benefited from the fact that at age 13 we did this and laid down these neuroplastic tracks way in advance of professional violin school or cello school or what have you. And so my question here is well, why don't we do that with radiologists? And so what I did was I got my friend's kid, my nephew, my son, Kathy's thing to read x-rays. And our argument was that teenagers could read x-rays to a serviceable level. And I'm not going to go through this in any detail because I don't have time, but they were aged 15, 18, 19, and 23. And with zero, they're completely non-medical engineers, high school students, whatever. And they did those same pediatric elbow x-rays. And we looked at their learning curves. And so that here's the task, here's what they did, what they looked at, and the same feedback as before. And what I want to tell you is that each of these teenagers achieved the mastery standard for pediatric emergency medicine physicians. And so our mastery standard from other studies done on pediatric emergency medicine fellows are that you have to be 80% accurate, 80% sensitive, and 80% specific. And if you hit all three of those 80s, then you've accomplished the standard. And so these guys took between 189 and 329 cases to achieve that standard, and they took between 4 and 18 hours to develop it as they went across. But they did it. And here's what the learning curve looks like for one of them. And so again, you're kind of a completely serviceable pigeon-like learning curve. And what we did was we Zoom recorded them reading unknown films and then did the same voice aloud that they had to do as they read these unknown films. These are films that they did not train on, but were separate and came across. And you'll be impressed with the words. The radiocapitellar line is off on the anterior posterior view and in the lateral view, and there's evidence of effusion, so I think a fracture is present. Sort of a deeper cognitive reasoning about a hidden kind of fracture. There's another one. It's unlikely that a radial neck buccal fracture, which you see at the arrow, could cause the visualization of a posterior fat pad. So they've identified a discordant pattern within this, and I would be proud of my PEM fellows coming back to me with this level of logic as they come across. And so so what this looked like in terms of them learning was me coaching one of them, and then that person coaching the next one, and then that person coaching the next one in a daisy chain of coaching. And they did thousands of cases as I showed you, or hundreds of cases as I showed you on the thing, but they did it. And so that these high school students were able to. And so it's feasible for novice learners. And we submitted this and are going to submit this as kind of an argument for wondering about the way we teach anatomy. And so we teach anatomy in a superficial way across a whole bunch of things. Whereas why don't we teach first year, take one thing and teach that to the depth of expert performance for a first year medical student, to show them anatomy in service of expert performance and create the whole, kind of stream of it, and allow them to have a sense of both breadth and depth in terms of their mental models of the anatomy as you come across. And so I'm gonna stop there in service of, kind of, if you guys have questions or comments or thing, and recognize that I've inflicted a lot of information on you, but I do want to, I do appreciate the opportunity to think in these different ways about something that is so fundamental to us in medical education, in health professions education, and so that so bring it across in that sense.
And that was great, and always so provocative, like you said, thinking about education and thinking about how we think. So welcome anyone's anyone's questions in the last few minutes. I will start with one though, which is, obviously, for the purpose of studying it too, and the examples you showed, there was a binary endpoint to what the learner was learning, whether they started out completely as a novice or an expert. There was a fracture, yes or no. Do you think it's the same learning process when you deal with the ambiguity of medical decisions at times? Because we all know those cases as well. Got 5 things going on. Do you choose to do treatment X or treatment Y first, understanding they could have pros and cons?
Mm-hmm. Yeah, great question. And so that so I don't know. My sense of it is that there's certain things that are boldly black and white that we can give black and white kind of feedback, sort of at 2 extremes of normal and abnormal. Our more recent work is around sort of these border cases in which some experts would call it normal and some experts would call it abnormal, where you would be appropriately uncertain.
Well, and one is, and I don't know the answer either, one is reasoning and one is what I think I'd call judgment a little bit. And it's a fascinating separate, maybe you'll come back for a third talk on that, that topic. Taiwan.
Yeah. Hi, I'm Hyun, and I am a radiologist. So this is a very interesting, it's a very interesting way to think about what we do. And I think there are some things, you're right, that we do, starting with Gestalt perhaps, but I think there are some other components that we might not be thinking about. And that is, there's a knowledge, right? That you say that there is the Gestalt, and then we look for careful search, but the careful search really can't be done unless you know what you're looking for to some extent, right? So there has to be some kind of a placement for the knowledge of the anatomy and the language with which you can describe things. And you kind of refer to that. And I've also taught high school students, 16, 17-year-olds, radiology, and you're absolutely right, they can learn. They can learn very simple things, but it is what Eric's talking about, the ambiguity and the judgments, that is much more complicated. And also, if you're thinking about the anatomy and you want to teach it in a much greater depth in service in medical school, I think that's really tough to do, because we radiologists spend years kind of understanding the anatomy of different parts of the body. And how do you convey that complexity to medical students in their first year? I think these are interesting questions to really think about.
Yeah, no, fascinating. You're completely right. And it's not to suggest that you don't need radiology residency. So I want to make that completely clear. But when you're on having the high school students do the fast part of the learning curve, and or the first year medical students or whoever, and just benefit from, kind of doing the thing in some depth. And then, kind of the fact that the flat part of the learning curve, the hard, inefficient work of learning absolute expertise, the way a radiologist is held to the highest standards, happens on rails that have already been planted. And my argument would be that we should explore your program for teaching high school students radiology, and to see, kind of to what extent do we get better radiologists at the other end of it. When they come to residency, having some sense of the visual landscape, some sense of how I get better, some sense of how to learn this particular skill. And so that's where I'm being kind of provocative. And so I appreciate you adding the richness to the comment.
Another thing I would kind of think. Oh, Eric, go ahead.
No, go ahead, Haiwan.
One other thing I would just think about is, the materials that we cover, certainly you can train even a pigeon to pick out the things, microcalcifications in the breast, mammograms, and so on. And I suppose that's not the difficult part, perhaps, to actually recognize something as being normal and abnormal, because we're certainly doing that with AI. But I suppose what I wonder about is we want to teach them how to think, the processes of getting to making those judgment calls in ambiguous cases. And as a radiologist, I can tell all of you here that we face ambiguities every single day. I mean, as physicians, we do. But those ambiguities are, first of all, medical students, students and residents, they're all uncomfortable with ambiguity. And so, I think it's really teaching how all of these people, including ourselves, to actually get to that point of ambiguity and dealing with it. I think that is actually what's really challenging. The recognition stuff, I think maybe AI can do a lot of what we're doing, but it is really the recognition of how to deal with, first of all, being comfortable enough to say, okay, I don't know, and I'm ambiguous about this, and then how to go from there. I think it's a much more challenging step. At least that's what I feel with the residents that I teach.
Fantastic. Thank you very, very much for that wisdom.
With that, I know the time is late, and I just thank you, first of all, Martin, for the 2 sessions back to back. Love it. And thanks to everyone for taking the time to join today, and welcome you back for some of our other events here coming up over the course of the spring and into summer. And always please check out the bei.Brigham and Women's Hospital website too for the full calendar. But look forward to seeing all of you back. Have a great afternoon, everyone.